features of Beckwith-Wiedemann spectrum, and sort of, you'll hear a lot more details about most of them as we go through the day, but this is going to be what do we see when we recognize the syndrome. So as has been mentioned, it's a multi-system disorder with a fair amount of variability in the clinics. And it's an imprinting disorder, which means that the genes function differently. The genes involved with this syndrome function differently if you inherit them from your mother or your father. And that complicates some of the molecular aspects of the disease. What are the drivers? In addition, there are several different mechanisms. So not only do you have to deal with imprinting, you have to deal with imprinting in multiple different genes. And each of those things modifies the phenotype and the expected outcomes a little bit. The presentation, as we will go through, can be as early as the prenatal period, and the oldest new patient that I have had was 68. So, and still having some recognizable manifestations, but doing reasonably well. Its incidence is 1 in 10,000, more or less, which seems common to me, but if you're not a geneticist, it might be rare. And then, as has been mentioned, described by Beckwith and Wiedemann. So this slide contains most of the information that we need for this talk, although there are some other slides. So the features have been divided into cardinal and non-cardinal features, and the ones on this slide are mostly the ones that are diagnostically useful. There are some other manifestations that aren't used as part of diagnostic criteria, although we will talk much less about those. So the one that stands out most to me is this one, macroglossia. Now in this case, macroglossia is very obvious. I think anybody would notice, wow, that's a really big tongue. It's less apparent over here, although you can see it. And most patients with Beckwith-Wiedemann syndrome, if you look closely, will have some degree of macroglossia. But some of them you do have to look quite carefully, and there are some patients with Beckwith-Wiedemann syndrome who do not have a macroglossia. And the overgrowth of one side compared to the other is a second major feature, and that is seen fairly frequently as an isolated thing. Now, one of the characteristics of the lateral overgrowth in Beckwith-Wiedemann syndrome is that the whole limb tends to be sort of equally involved. You don't have a finger or a toe typically that outgrows the rest of the surrounding tissues. It's the whole arm or the whole leg, or sometimes one whole side of the body that grows. There are other causes of lateralized overgrowth, and especially if you have sort of focal areas where one part of a leg or one part of an arm is overgrowing the rest, you need to think of those other conditions. Omphalocele is a pouching out of the intestines at the belly button. It is usually covered with a membrane, and that one clearly needs surgical intervention, so is very important from a management standpoint. So this hyperinsulinism, this bright spot here is where the pancreas is, and it should be the same color as these tissues, mostly. And it's lighting up because they put in a tracer to show us where it is. But if your body is releasing too much insulin, that causes blood sugars to drop, and low blood sugars especially in the newborn period, is a big, it's an important finding, both from a management standpoint and from a diagnostic standpoint. Now, this image shows the kidneys here and here, but the kidneys should not have these lumps in them. Those are masses. If you have bilateral Wilms tumor, which is a kidney tumor of early childhood, that causes, it's a very rapidly growing tumor. It tends to metastasize early, and that can become a life-threatening thing. One of the reasons that we hold meetings like this and pay so much attention to Beckwith-Wiedemann syndrome is because of that complication. It's it's a treatable tumor, but the treatment is much easier and much more successful when we recognize it early. Some of the other features that are common, but not as diagnostically predictive, are, so nevus simplex is this red patch on the forehead. There's sometimes extension onto the eyelids. And that is something that is seen with reasonable frequency in the general population, but is much more likely in the context of Beckwith-Wiedemann syndrome. This macrosomia is just big baby, and as probably most of you already know, but babies that are large for gestational age, or that are just very large babies, are more likely to have Beckwith-Wiedemann syndrome, especially if the mother does not have risk factors for macrosomia. Now this picture says organomegaly, but you can't see organomegaly in the picture. The internal, so the same way that you can have limbs, one arm or one leg bigger than the other, you can also have just internal organs. You can have kidneys that are larger than normal, liver, adrenal glands are the most common ones. And identifying those features, again, is an important clue as to diagnosis, as is umbilical hernia and some unusual creases like this one, or pits on the external ear. Now, the external ear findings and the nevus simplex have no functional implications at all. And then this right here, this is the liver, and right here is an area that's different in signal in the image, and that is a liver tumor. Like the Wilms tumor, it's a very fast-growing tumor, and it's one that starts very early in childhood, and it's actually essential that we diagnose these as early as possible to get best outcomes. The treatment success is much better. It's in the 95% range if we catch it early, and the treatment protocol is simplified by early recognition of the tumors. The placenta being larger than normal is another diagnostic clue, but doesn't have a lot of management implications because there's not a lot we can do about it. So we mentioned the prenatal period. Several of the findings that we talked about on the last slide are identifiable on a prenatal basis. So this is an image from a patient with Beckwith-Wiedemann syndrome. And this child did have an umbilical hernia, but you can't see it in this cut. What you do see is that the tongue, which is right here, is bigger than we would expect it to be most of the time. So if the tongue is big enough that you look at it and say, wow, what's that? Or notice that the facial proportions are different, on a prenatal image, that's significant. And if you see macroglossia on a prenatal image, the top thing on your diagnostic considerations should be Becker-Wiedemann syndrome. There are some other conditions that can cause that. Another thing on this particular image is that so the diaphragm is right here, but over here you see some stuff sticking up into the chest that is it's supposed to be down here in the abdomen. This is a diaphragmatic hernia that's also increased in Becker-Wiedemann syndrome. It's not part of the diagnostic considerations or diagnostic criteria. So the things you can see, and that should, if you see those things on a prenatal case, should make you think of Becker-Wiedemann syndrome. Omphalocele is the most common, and especially omphalocele in a large for gestational age baby. Macroglossia, my experience is that if I don't ask questions about the tongue size, the radiologists or the obstetricians never comment on it, no matter how big it is. So if you see an omphalocele, ask the person doing the imaging about the tongue size. I don't know how many of you would be involved in that kind of care. So enlarged other organs, particularly kidneys and adrenal glands, are also important. And again, in the context of omphalocele or large for gestational age, asking about those things will get you a better reading on the imaging. And then a mesenchymal dysplasia, which I'm not going to talk about in the detail here, is something else that you might be able to detect on a prenatal period. And then, as I think we'll hear more about later, a history of assisted reproductive technology is also associated with higher chance of having Becker-Wiedemann syndrome. So after the delivery, this is the time when we diagnose most of the patients in the neonatal period. But what we look for is large babies. A lot of them will be 9 pounds or more, but not all of them. And I, in fact, have had a couple of patients who were small for gestational age. So lack of large size does not rule out Becker-Wiedemann syndrome, but it does help to make the diagnosis. Any baby with an omphalocele should be examined to look for Becker-Wiedemann syndrome. And one of the things you want to look for is specifically assessing tongue size. Babies who have Becker-Wiedemann syndrome are prone to low blood sugar levels. Some of them that will be of long duration, but many of them it will only be in the first few days of life. And then hemihypertrophy, and one of the questions that gets asked is, well, how big does it have to be? If you can look at it and notice that one side is bigger than the other, that's enough hypertrophy to count. But we do recommend that you measure the length and girth of the limbs to document that so you can see if it's changing over time. And then embryonal tumors, which are Wilms tumor, hepatoblastoma, and sometimes neuroblastoma. So the diagnostic criteria have recently been updated. So the cardinal features, which we mentioned before, macroglossia, omphalocele, hemihypertrophy, bilateral Wilms tumor. You can have just unilateral. You don't have to have bilateral to count it as a feature, but bilateral is more compelling. Hyperinsulinism, and these are worth 2 points each. And then these other things, macrosomia, nevus simplex, polyhydramnios, or placentomegaly, ear creases, hypoglycemia, these get 1 point. You need a total of 4 points to have clearly confirmed the diagnosis. But that's not what I find the most useful. The most useful thing is that if you pass this, 2 points, you need to think about it. So if you have 2 things over here or 1 thing in this column, then you need to think, could this be Beckwith-Wiedemann syndrome? And then look specifically for the other things. If you get up to 4, you can make a clinical diagnosis. If you don't, then, but you still suspect that it may be the diagnosis, doing molecular testing is appropriate. We'll talk in a minute about some of the complexity of that. Okay. Now, what if you have a patient where the baby isn't large for gestational age? So, large for gestational age, meaning over the 95th centile, only happens in about 50% of the kids. So, not everybody, and as I said, some of them are not even big babies. What if you don't have obvious macroglossia? Assuming that you've opened the mouth and actually looked at the tongue, but not all of the kids are going to have any macroglossia. So you have to take it in context. You have to look at the bigger picture, and you can be missing some of these things and still have Beckwith-Wiedemann syndrome. If you only have isolated hemihypertrophy, that is a reason to consider genetic testing for the condition all by itself, as, in my opinion, is macroglossia as an isolated finding. So, organomegaly with no other external features. So if you have big kidneys, but you don't have anything else, I don't know that people would recommend testing, but it's possible to have Beckwith-Wiedemann syndrome with that as the only finder. Okay, Beckwith-Wiedemann spectrum is caused by dysregulation of genes on chromosome 11 at the P15 region, and it involves a dysregulation of growth. Now, it does matter for this imprinting area, it matters which parent it comes from.